London in UK will talk about the use of artificial intelligence to predict and prevent intraoperative hypotension. Welcome, Professor Monty.
Thank you. Science is called Hypotension Predictive Index, which we can use today in the operating room. So it's currently available certainly in the United Kingdom, Europe, and the United States of America, and we clinically are using it in our operating rooms as we speak. So some potential conflicts of interest. So I've highlighted the main one for this talk, which is I am a paid consultant for Edwards Life Sciences. The other potential conflicts are mainly academic, including my role as the editor-in-chief of Top Med Talk and the director of Evidence Based Peri-operative Medicine. So as you've been hearing from our previous two speakers, we're all now commonly speak about things like big data, artificial intelligence or AI, machine learning, neural networks, computer vision, natural language processing, and deep learning. How many of us truly understand those things to the depth of knowledge we've just heard from our two previous speakers and Professor Schaefer as well? I'm not sure. I mean, I use many of these words, and I'm not sure how much I really understand about them, but I am very excited about what they have to offer to our specialty in particular, and I do have now some considerable hands-on experience with one particular form of AI in practice. This, what this image here refers to has already been referred to a certain extent. It was the clip that was shown to you from Professor Stephen Schaefer's lecture referred to the threat that some people feel from computers and the fact that the computer might end up doing our job. This is a classical piece of art. Around the time of the transition from the agricultural revolution to the industrial revolution, and within it we see a horse, we see a cart, and we see a wheel, and the building on the left-hand side is a mill. And the humans at the time were very concerned that by the Industrial Revolution and all the mechanistic components that come with it, is that they would be out of a job. Whereas what they needed to worry about was the horse, because it was actually the horse that decreased dramatically in numbers, not the human beings. They actually thrived and developed more jobs and more tasks and more opportunities by adapting, while the horse dramatically reduced in numbers as it was replaced by steam engines and subsequently alternative technologies. The modern equivalent of the Industrial Revolution development of the internal combustion engine, for example, and the fears that some people had, is probably the microchip. So this is an image taken from Wikipedia discussing Moore's law. Now, we've all heard of Moore's law, and we all have our own different interpretations of what Moore actually said. Now, when he said it, that's Gordon Moore, the co-founder of Intel, in 1965, I think the accurate quote, remembering this is 1965, was that following the development of the microchip, of which we think it was by Noyce, the co-founder of Intel, in about 1959, is that Moore said that as microchips would get twice as many transistors year upon year, therefore doubling their power to compute, that the price of the computer would halve every year. So 2 years to double the computing power of the chip, and every year the computer would drop by half. Now, a version of that has followed through. That is the sort of exponential growth in the ability of the microchip to be able to deliver computing power. What we're now told, whether it's true or not, it's often debated, is that the computing power that we have on our regular mobile phones, if we have a smartphone, or indeed the computing power in fancy toasters like this variety here, is greater than the computing power that the Apollo mission had to help it to land on the moon in 1965. And I'll come back to that at the end when we discuss whether computers are here to take over or the computers are here to help. Now, the Apollo mission, from 1959 to 1965, there was already a huge development in computing power. The Apollo craft did have a pretty hefty computer on it, but not quite as clever than that is in the toaster shown in this diagram at the moment. Now, you've already heard about numerous examples of how artificial. We're also told things like the self-driving taxi is here already, to a certain extent, and will be with us commonplace relatively soon. The thing that made me relatively recently think that all of this is going to very rapidly become a complete reality was this article from DeepMind about AlphaZero. Now, I'm sure we all remember when we heard about the computer that beat the world chess champion. The work from Demis Hassabis and his colleagues around the corner from where I work in London, where they developed a computer program, and the computer was programmed in such a way that it could beat a chess champion. A degree of artificial intelligence and learning went into that. But they had to teach and train that computer. That actually, for those of you who've forgotten about this, that was actually 20 years ago that Deep Blue led to the formation of DeepMind, as I understand. Now, this article, which is about AlphaZero, is from just 3 years ago. And what made me really sit up and listen to the folks working here was when they said that they plugged the computer in and switched it on, and it then started to self-learn. So having never been told about chess or shogi or the game Go before, once it was plugged in and switched on using its general reinforcement learning algorithms, within 24 hours of the first person playing a game chess against the computer, it had learned how to play chess. And within 24 hours, it could beat the world champion. That's a real tipping point, I think, from the sort of idea that we have microcomputers through to something that does a level of sophisticated thinking that could be really helpful to us. But as you've heard from previous speakers, I don't see in any way, shape or form it's going to replace us. I think that was articulated extremely well in the last talk. I think it's going to help us as much as we allow computers to help us. And I think in the world of anaesthesia intensive care, we have very many needs here and now where I think we could do a better job if we let the computers help more. So this is the reason I chose the title of the talk, the first slide I showed up. I was privileged to appear in this article, making some quotes about the Hypotension Prediction Index from Edwards Life Sciences, published in the Wall Street Journal just a few years ago. I've actually in front of me at home, I've got a copy of it from May the 21st, 2018, where it talks about a number of examples of AI that are being used in medicine at the moment. And you'll be aware of the imaging examples and a number of other examples that are growing rapidly. I was specifically referring, because I'd worked with it, to the Acumen Hypotension Prediction Index from Edwards Life Sciences that uses a form of AI to predict hypotension in the ICU or in the operating room, for example. And this screenshot, which is directly from the article quoted here, shows the HPI number as it was portrayed at the time. So it's a number from 0 to 100. Now no longer, for regulatory reasons, allowed to be called a percent, but this is 96 out of 100. And in this historical screenshot, it's suggesting that the patient is extremely likely to become hypotensive soon. So it's that I'll expand upon for the next few slides, using some slides directly from Edwards Life Sciences, also referring to the published literature, which has already been referred to a certain extent, that you can find on PubMed and via various different search engines, because the development of this particular technology is in the public domain. It is not a black box. So HPI exploits the arterial waveform. So as it can use the arterial waveform gathered by Edwards Life Sciences transducers, it looks at variability. So now you have a heart rate variability, for example. And we know that in health, we have a normal heart rate variability. So it exploits variability, the dynamic associations with the changes of the signals. So because we breathe or are being artificially ventilated, we have dynamic associations as well as natural variability. And we also have complexity of the waveform. So we're familiar with the arterial waveform normally having this sort of shape with a diacrotic notch, and that can change depending on different shock states, for example. So lots of rich signals to harness. The technology, as I say, the principal signal that Edwards Life Sciences has to work on is the arterial waveform. Now, therefore, you can immediately see that the quality of the acquired arterial waveform is critical. So if you don't have a quality, well-validated signal coming in, well-standardized signal, you're going to have problems making sense of what the computer thinks it's telling you. But let's assume that we've done our work and we've made sure that we've set up our arterial lines appropriately and we've checked to make sure that they're calibrated appropriately. Now, within the arterial waveform, with a computer helping you, there's very rich signals from numerous different time points. We can talk about systolic onset, the systolic phase, for example, the position of the diacrotic notch, the diastolic phase, etc. And we can start to divide that up with the help of a computer to give us very, very many rich signals. The development of the HPI itself is a classical training validation model. So for those of you who are interested, you've heard from the previous two talks in this idea of learning, of various different levels of learning. This is a very classical way to start. So the scientists at Edwards Life Sciences took data from 1,334 patients. So I said this is published in an article that's already been referred to by Hatib et al. They had a training set of 293 patients and a cross-validation set of 1,041 patients. So training, cross-validation. Now, patients I understand were adult patients undergoing major surgery and in the intensive care unit. So if you have questions about validity in different environments, it was developed from a population, I believe, predominantly in California, adult patients from those two different backgrounds. Now, the number of events, and an event here is referred to as hypotension below a MAP of 65, or a non-event, which is a mean arterial pressure above 75. And note there is a zone there between 65 and 75. You can imagine there are a lot of events, in other words, single episodes below a MAP of 65, and a large number of non-events, so a MAP above 75. If you look at the number of cardiac cycles, so now the computer and the young, bright people are going to be put in front of these super processing computers are going to have 31.45 million cardiac cycles to work with of the event subset, and just under 102 million cardiac cycles to work with. And those of you who are into this, you know that the people who work in this field love massive data sets. The more data they can get hold of, the better. The input variables that principally inform it, now remember, as we said already, it's working principally or almost entirely with the arterial waveform. So if it's counting heart rate, for example, it's counting RR interval, not an ECG. The real-time waveform features are, as we referred to already, that changes in variability, the complexity, and the dynamic associations. Now, when you let a computer and a team of data analysts go at it, they can discover over 2.6 million features derived from the arterial blood pressure waveform. And in this context, a feature is a variable. They then take those 2.6 million features, those variables derived from the arterial waveform, and look at individual performance analysis, primarily based on this ability to predict a mean arterial pressure under the threshold of 65 millimeters of mercury for greater than 1 minute. And they then do a second sequential feature selection to reduce it to the 23 most predictive features. And they then start to do the mathematics within that. So they multiply some things by each other, they square some things, they do the square root of other things, and eventually perform what is basically a logistic regression model using those 23 most predictive features, create a decision boundary based on, as we said, the hypotensive, non-hypotensive. To say one more time, hypotension is a MAP below 65, not hypotensive is a MAP greater than 75. So there is this grey zone that we might talk about a little bit later on, which very occasionally creates a challenge, but you have to have the above or below components of it. And then what they give you at the end of the day is they give you a number on the monitor, which we must remind ourselves is not a physiological variable, it's a predictive indicator. Here's HPI, for example, here, starting off in this example here at around 50, rising very sharply to above the danger threshold of 85, going up to about 90 or so, around the same time that mean arterial pressure is sagging around the time of induction of anaesthesia. Now, if we just look at MAP here, going from about 85 down to about 75, I would suggest that if anaesthesia had been induced and everything looks okay, that we would probably be saying, well, I think this is a pretty stable patient, running along with a MAP of about 75 for that period of time. And yet here, something happens later on that the patient becomes hypotensive. Now, the computation within the Edwards device that has derived the HPI number is saying, based on the analysis that the machine is doing on our behalf, it is saying right back here that that little drop in pressure has resulted in a patient who now has an almost 90% chance of having a hypotensive episode 15 minutes later. So now, how does that work in practice? Well, you don't treat HPI. What you do is you say, I wonder if that is true. I wonder what might be happening to my patient that I could do something corrective about preemptively to stop that hypotension happening. Is it a little bit of blood loss? Is it too much anaesthetic? Is it early sepsis? Let me have a look around and let me think about that and see what I see. Now that's, if you haven't seen HPI before, that's quite hard initially to conceptualize. So what I'm going to show you here is a video recording. I hope it plays well for you. I know this is sometimes challenging on Zoom. Taken from a laboratory in the USA. It's a series of work done by myself and Dr. Simon Davis, which has just been accepted for publication in Analgesia and Analgesia. And it's a large, anesthetized large animal model that we're going to hemorrhage for the purpose of looking at hemodynamic changes and the microcirculation, which I'll show you in a moment, and the impact of vasoactive agents on the main numbers we see up here at the same time as we look at the microcirculation. So here's our monitor screen at the top left, which I'm sure we're all familiar with most of the numbers. We've got MAP, stroke volume variation here, all looking fairly stable. Here's our new number at the top, 23 out of 100, which is the HPI. So it's saying there's a low probability at the moment that this animal will become hypotensive in the next 5 to 15 minutes. The trend lines on the right we're going to ignore for a moment, but just in case you're very eagle-eyed, it's cardiac output, it's MAP here, it's stroke volume variation, it's systemic vascular resistance in here. So now we're going to start our hemorrhage. And I jump this forward a little bit by bit. This is a scale here. We've got about an 80 mil hemorrhage at the moment. I'll jump that out fairly quickly. Here we are going out to 160 mil hemorrhage. You can see already, if I pause, the HPI has jumped up by 15 points. So very early on, there's a kick up in the hypotension prediction index that says the likelihood of hypotension has increased from baseline, even though our mean arterial pressure, our stroke volume, and our stroke volume variation are not suggesting there's anything wrong at all. Now, if we can see all the blood loss, we can see there's 168 mils in the bucket. So we'd say, well, I don't need your fancy number to tell me that. But if that's accumulating on swabs or in the gutters, you've got a significant heads up with regards to what could happen next. And as I emphasize, the same thing applies for example, depth of anesthesia or the early development of sepsis. So let me take you forward. As we all know here, your high-end hemodynamic variables are very, very late predictors of hemorrhage. We all know that heart rate, for example, is not a predictor of hemorrhage. And we also know that our compensatory mechanisms for hemorrhage, which squeeze unstressed volume into stressed volume, maintain central blood volume and mean arterial pressure. So here's 250 mils. In this model, that's about 5% of blood volume. The HPI is now saying that hypotension in the next 5 to 15 minutes is more likely than not. If we take it out a little bit further, 350 mils out here, we can still see that MAP, heart rate, stroke volume, cardiac output are all maintained as we might anticipate. Take it out a little bit further. We're going out here now to about 500 mils of blood loss, which is about 10% of blood volume. The mean arterial pressure is sagging just a teensy bit here. I'll just let that run for a moment there. Our HPI is saying highly likely now to have hypotension coming soon. MAP still looking pretty good at 72. Cardiac output is 7.5 litres. Our stroke volume is 106. Our stroke volume variation is 16. Let's take it out to where you'd expect to see some hint from stroke volume variation as you get to a point of central hypovolemia. We're out now to our HPI screaming at us saying, come on, this is serious. This patient is definitely going to be hypotensive soon. And down here we can see that we're more than 10% of blood volume. Our MAP is just starting to sag. Stroke volume variation being maintained, but SVV just kicking up. So I'll take that out further to you. It's now saying, you know, it really is too late. MAP is just about to drop below 65, and now with a heads up from when HPI first changed, we have over 20 minutes of prior warning to the hypotensive episode. Now, this hemorrhage model is an extreme example, but it's a very good way at trying to understand at which points the various different variables change. Now, here is on the big screen on the wall inside the laboratory. And what we can see here from a different model is a healthy blood pressure. We've already started hemorrhage back here. HPI is kicked up. In this example here, stroke volume variation has kicked up as well. But we have a cardiac output of 7.3, etc., etc. Now, added to this model, because one of the questions would be, when HPI changes, does it change at the same time as we make compensation in our splanchnic organs, for example, and compromise splanchnic blood flow as a result to squeeze unstressed volume to our central blood volume? Do those things occur at the same time? We introduced a side stream dark field imaging camera into the GI tract of the model so we could look real time at microcirculatory flow. And it's this paper that is in press in Anaesthesia and Analgesia. And in this particular model, we also intermittently gave vasopressors to look at the deleterious effect of using vasopressors alone to reduce HPI, as opposed to using a combination of volume and vasopressors. We don't have enough time to go over the detail of that tonight, but I'll just show you a few little images. This is Dr. Davis here on the left from York Hospital in the UK, along with Thomas Shearing, has got some of the greatest experience clinically with HPI in the world. And this is one of our medical students doing an intercalated BSc. And I'm pleased to say that her dissertation won her the top BSc dissertation for this work at UCL this year. Here's the SDF camera being inserted into the bowel of the animal. And I hope this video plays okay for you. Sometimes I don't come over that well via Zoom, but this is a side stream dark field image of the gut mucosal lining of the GI tract. And we can see here very well preserved microvillus structures, the centrilobular vessels flowing up to the tip of the microvillus and around with constant flow as happens in the microcirculation. If we take that one stage further on, here is following about 500 mils of blood loss, so around the 10% of hemorrhage. And we now have blanching of the microvillus because we've squeezed the blood out of the splanchnic bed to maintain a heart-lung brain circulation. Our heart rate, our blood pressure, our stroke volume, everything looks perfect because the animal, as we do in humans, compensate to keep everything looking good. But this is post-operative nausea and vomiting, or ileus in the making. If we go on to just compare those images side by side, again, I hope this comes over on Zoom. I realize that sometimes it's challenging, but I can let you have all these images later by arrangement. You can see here very healthy microvillus compared to a compromised GI tract. Now, the purpose of this particular set of experiments, I'll which I showed you this image earlier on. I showed you the effects of hemorrhage and the rise in HPI and the effect of the microcirculation. The purpose of these set of experiments, which I said is in press now in anesthesia and analgesia, is the changes during a phenylephrine infusion during the model. Because one of the things that worries us about having predictive indices, things like HPI, is as it was elevated back here, it's telling you that hypotension is likely to happen back here at around the 60 out of 100 level. But it doesn't tell you what to do to stop bad things happening. And in this example here, we have given a phenylephrine infusion at this point here, which was the wrong thing to do, but is not an unusual thing for people to do. And by giving the phenylephrine infusion, we've made HPI go back to normal. We've made stroke volume go back to normal. We've suppressed stroke volume variation. We've produced a lovely looking cardiac output, and the other variables are looking very good. And we've restored our mean arterial pressure to baseline, which was around 105 millimeters of mercury. Here it's 106. But when we look in the GI tract when we do that, so we've made everything look good with vasopressors, the GI tract is dying at this stage. This is a blanched, dying piece of gut mucosa. The only movement is that coming from the great vessels. There's the slurry flowing outside the mucosa at the side here is not blood flowing within the gut. It is slurry flowing outside the gut. This is dying GI tract. Now, if you do that to a patient, they'll probably get away with it. They'll get severe postoperative nausea and vomiting. They'll get an ileus, postoperative GI tract dysfunction. But the unlucky few will go on to get translocation, systemic inflammatory response syndrome, and full-blown multiple organ failure. So HPI has got a lot to offer, but it doesn't oblige us to do the right thing to correct the abnormality. So we still are there with the computers to help us, but we're the ones who have to make the decision. So a couple of closing articles just to refer to. This is one of the first trials that's been done, the HYPE randomized clinical trial, looking at devices, HPI in particular, and its ability to modify the occurrence of hypotension perioperatively. So a positive result with regards to reducing the incidence of hypotension, but not yet of a magnitude where one could turn around and say that it made a difference to outcome, encouraging signs and signals there. I'd also like to, as the other speakers have done, have emphasized what I think will be the very big difference here is that now you have things like additional predictive indices and numerous different things that could be modifying the predictive index. It's starting to get beyond many human beings' ability to analyze all the input variables and make the right decision without some decision support. Is it the volatile anesthetic agent? Is it hemorrhage? Is it somebody pressing on something? Is it the early development of sepsis? So the more those signals are integrated, the more we probably have to start to let multiple closed loop systems or semi-closed loop systems, what is I think is best referred to as fly-by-wire, help us to make these decisions. Now, what do I mean by fly-by-wire? Well, as I said, the computers have the ability to help us, but we don't necessarily want them making the sole decisions. As the example you heard about, they can end up giving ill-thought-through advice. It might be good at beating the world chess player, but it's not the same as making the right decision about giving out cancer treatments. So my last comment is to refer to, as I said, the fact that man only managed to land on the moon because we had the early development of microchips and the computers were there to help. This, I think, wonderful series of podcasts, 13 Minutes to the Moon, which was led by Kevin Fong, who is a professor of anesthesia, talking about the final 13 minutes of the release of the craft to land on the moon. Within that, Neil Armstrong, at about episode 4, refers to the moment where the most elite pilots that they could find came to the realization that they were just not good enough to be able to fly the lunar module. It was too complicated, the reactions were too complicated. So the computers were put in there for them to have the translation of their movement of the joystick equivalent to and let the computers refine it to land the craft on the moon. Now, in that particular final episode, Neil Armstrong refers to the fact that the computer in the final moments of landing on the moon was doing a fantastic job, but as he looked out the window, he could see that the computer was about to land on a great big rock. It had no way of seeing that great big rock. It wasn't developed enough at that stage to have eyes and to have a decision system that allowed them to modify for that. Maybe it would now, but it didn't then. So Neil Armstrong took over for a moment, and he allowed the spacecraft to glide along vertically with the computer's help until he could see a nice big crater, which was a nice big open space that we all know very well. And he said, now computer, back over to you. Could you please land the craft? So I think our future in medicine, but very much in anesthesia and intensive care, is going to very rapidly have a lot of fly-by-wire systems where we're still making the decisions, we're still choosing the therapies, we're still choosing the targets, but we're going to get much better at hitting those targets with the help of the computers. I hope that was helpful and interesting. I will share my slides, and if the images didn't come over very well, we'll work out a way of getting the videos to you. Thank you very much for listening.
Thank you so much, Professor Monty. And I think we have some questions about the gut mucosa perfusion. It is increased with fluid replacement or with blood transfusion. What do you think?
Well, it's definitely corrected with volume replacement. There is a point where that volume replacement needs to be blood and blood products. But as in any standard setup, you can do a lot of that with blood-free components in the first instance. So it's a longer story, but in the experiment, we did sequential bleeding and retransfusion and bleeding and retransfusion. And you can restore the blood flow with a crystalloid infusion up to a point.
All right. And another question about the fluid preload before expected hemorrhage. Is it useful for delaying drop in the hypotension perfusion index? Preload before the expected hemorrhage.
To preload before, you mean should one preload the patient in anticipation of a hemorrhage? Is that, I didn't
think
quite...
it is not a good practice because the patient will be hypervolemic, and the hypervolemia injures the endothelial glycocalyx. So if the patient is volemic, I think no need for the preload. What do you think?
Well, I'm a fan of co-loading. So I do think there is a requirement which is physiological for a slightly higher blood volume around the time of induction of general anesthesia. I think that is scientifically robust. And if it's co-load, you should not create an increased right heart pressure, and you should not damage the glycocalyx. But those are all based on first principles. I think the closest you can get is the relief trial from Paul Miles. They did give a 10 mil per kilo load at the beginning and did get better results, better outcomes.
All right. In your experience, what do you think, who is the patient we should use this monitoring for him? Cardiac patients, major surgery, orthopedic surgery, liver transplant? What do you think we have?
Well, I think it's a journey of discovery.
For HPI, yeah.
Yeah, I think it's a journey of discovery. I mean, this is very new technology. So therefore, I think what we have to do is to embrace what it may have to offer and to learn by doing. And I think all major surgical cases, there's potential benefit at the moment. There are multiple evaluations going on around the world of all types of major surgery.
All right. What is the factors which may cause false reading for HPI or may interfere with the proper reading of HPI?
Well, the two very common ones where you can get misled. Well, there's one thing you have to say about HPI is you can't predict an accident like the surgeon making a hole in a vessel suddenly. So you can't predict those sort of unexpected events. The major one that creates a challenge is when patients end up for some reason in the grey zone between 65 and 75. You can get an elevated HPI number in an otherwise stable patient. You get used to that over time. As you say, you learn by doing, and I think many of those potential current imperfections. It's probably wrong to call it an imperfection because it is doing what it's designed to do. It's just in order to be able to develop the technology and get it proved, you had to choose a lower threshold and an upper threshold. So if you end up with a patient that's permanently in that grey zone, it can be more difficult to interpret.
All right. If a patient coming, for example, with septic shock due to surgical reason, acute abdomen, for example, and I already take the patient from ICU in nor-AP or dobutamine, inodilator, vasodilator, in vasoactive medication. So can I use HPI or it would not be accurate with these medications?
Yeah, it does. And there's every reason why it should be, because it was developed by using learning cohorts that included critically ill patients, as you describe. In other words, patients with sepsis on vasoactive agents.
Yeah.
It then, as we were trying to sort of demonstrate in the porcine model, if you're doing, let's call it the wrong thing, if you're taking a hypovolemic patient and you're over vasoconstricting them, quite rightly, HPI will tell you that this patient is not going to become hypotensive soon, but it doesn't mean that you're treating the patient correctly. So it can only tell you what it's designed to tell you, and that is the likelihood of a hypotensive event. And it is valid in the context that was asked about. In other words, with sepsis, with the use of vasoactive agents, it is still predictive.
All right. Some patient may be on fluid restriction, maybe because of heart failure or chronic kidney disease, and they may be for any reasons. So is it still valid to use HPI?
Yeah, and if you have very severe right heart failure, you're going to reach a degree of severity of right heart failure where you're probably not getting an anaesthetic anyway, and HPI will not be reliable under those circumstances. But if you think it's appropriate to be judicious with your fluids, like the examples that you chose, the patient will still need volume replacement if they're hypovolemic, but you're going to be much more judicious with your volume treatment. And it's still valid. It will still, and to a certain extent, it's more useful in those patients.
Okay, yeah. Some questions about if the patient has already hypovolemia or hemorrhagic shock, and I try to resuscitate him to give fluid and give blood. How much is a correlation between the correction of hypovolemia and the sensitivity of HPI? It can give me a good response that I can stop at some stage?
Yeah, well, I think the answer to that is we think so. That's our personal experience. And there is work ongoing to address that in a way that will allow it to be presented in a publication. But our personal experiences are that if you're giving volume replacement and it's appropriate, HPI comes down in response to the volume. Now, if you have hypotension and your volume therapy is going to take a while to restore the volume, it may be necessary to give a vasopressor to restore a heart-lung-brain circulation while you wait for your volume to catch up. So, how we were always trained still applies. It's good to do your best to keep the heart-lung-brain circulation in crisis going while you restore the other variables.
All right. What is the effect of the surgical stimulation in HPI? Do you think there is some effect?
Yeah, it does. It does change with everything that changes your autonomic balance seems to affect HPI. So one of the reasons you look around, you might say, well, that's a little bit unusual. I'm not sure what's happening at the moment. Maybe someone is pulling on something. Maybe someone is pushing on something. The important thing is it prompts you to look and ask. It doesn't necessarily prompt you to do. And it's not a physiological variable. It's a warning. It's like the weather warning thing on your phone. It says there's a good chance it will rain this afternoon. It doesn't mean it will rain, but you might want to take something to protect you from the rain because the chance, it's not saying it's just not going to rain. So,
all right. Yeah. All right. Professor Massimo, sure you have some comment.
Yeah, so as any technology, I believe the main issue is to bring it to the, as I say, the man of the street, because if it's only used by an elective or a pool of people around the world, it will not be effective. So what do you think it will be the next step of HPI? Mainly, can we think that in the future we can miniaturize this technology to put in like in a finger cuff and to have it used even in out of hospital where we have the majority of trauma, or for example in remote areas, or nowadays where in ICU we cannot really reach the patient because there is COVID, and so we can predict if the patient is developing hypovolemia and we have to correct hypovolemia before it will become symptomatic.
Yeah, I think yes is the short answer to all of those points and all questions. And it is, thankfully, it is all happening as we speak. So less invasive, broader use, greater access. And it will happen, I think, rapidly now, as it has happened in the rest of our life.
All right. The last question for myself, sure you use the HPI a lot in your clinical practice every day. So, from your experience, what is the most valuable issue in the HPI? Limited IV fluids, or actually the patient less hypotension, less post-operative cardiac complications? What do you think?
So I think it's more appropriate fluid and hemodynamic management, and we're hoping that will translate through to better outcomes post-operatively. Now, as with any new technology, it's not going to happen that on day one everyone gets it on every monitor in every operating room and at every ICU bed. There's always a period of evaluation, of which we need the enthusiast to do the evaluation, because like with all of these things, we learn by doing. You know, it's I don't know if anyone's old enough apart from me to remember the arrival of pulse oximeters. You know, even though that seemed bland or obvious, we had to learn by doing. So there's then a whole load of publications about the color of nail varnish and obvious things that follow the learn by doing experience. So
if we take advice from you, who is the patient to start to use it? Major surgery, as you mentioned?
Yeah, I would, because it's a much cleaner signal, I would go for elective major surgery to learn in that space. I think cardiac's a pretty good space, because if you're doing bypass surgery, you've got the pre-bypass window and the post-bypass window, which throws a lot of variance, and just big cases in the OR. But I think it's for the enthusiasts to join in the voyage of discovery. Because...
All right. Okay. Any more comment, Professor Massimo?
So one thing that I believe is interesting is to integrate this signal with the main other clinical and even vital signs that we have, you know. So remember again, hypoxemia is one of the main problems post-operatively with hypotension. So if we put that together, you can even avoid 30% of the post-operative complication. And the failure to rescue probably will be a minor problem. So we still miss this part, that there is a SpO2 and there is monitored sometimes, sometimes not. And there is hypotension that is not monitored routinely.
I agree completely. So we are, as many people are now, we're involved in an international collaboration to try and use as much information as possible to modify risk iteratively during the patient journey. It's, you know, our colleagues who do the computing for us are hungry to help, and they have the ability to help us now. We just have to have the willingness to allow them to help. So, you know, we can't overwhelm them with data anymore.
All right. Okay. I think there is no more questions. Do you like to add any comment, Professor Massimo, or all done?
No, thank you.
Okay. Thank you very much, Professor Monty.
Thank you very much.
Professor Massimo.
Stay safe.
Very, very interested lecture, and I hope to see you soon in Abu Dhabi, inshallah. Thank you very much.
Inshallah.
Thank you.
Thank you.
Thank you.